Okay, this time we're starting off on the respiratory system, And the respiratory system had some functions. Its function was to supply the body with oxygen and to remove carbon dioxide. In order to carry out or accomplish those functions, there were 4 processes that our respiratory system had to carry out. We had to ventilate. Ventilate was to move gas in and out of the lungs, and we call that breathing. We had external respiration, and that's the gaseous exchange that occurs between the lungs and the capillaries. Then there was transport of our respiratory gases, and that was a function of blood, carrying our highly oxygenated blood out to the tissue and bringing our carbon dioxide back to the lungs, so transport. And then internal respiration. Internal respiration was the exchange of gas between the capillary blood and the tissues. Collectively, we call those processes respiration. That will be your discussion question next week. The discussion question is going to say, list the 4 processes and explain one. Easy. List the 4 processes and explain one. We went back to our respiratory system and we talked about the functional anatomy of the respiratory system. We divided our system into 2 zones, a conducting zone and a respiratory zone. The conducting zone included the nose, the pharynx, the trachea, the nose, the pharynx, the larynx, the trachea, and the bronchi. All of those macroscopic we could see. The respiratory zone is the site of gaseous exchange. All of those guys are microscopic. The bronchioles, the alveolar ducts, and the alveoli. We start back up at the top and look at each individually. The nose and paranasal sinuses. The nose is a passageway for respiration. It moistens, warms, filters, and cleanses the air. It is a resonating chamber for speech. It houses the olfactory receptors. All of those things. The paranasal sinuses are in the frontal bone, the sphenoid, the ethmoid, the maxillary bones. The sinuses lighten the skull. They assist with warming and moistening the air. Rhinitis, inflammation of the nasal mucosa. The pharynx, the nasopharynx, is a passageway for air. The uvula and the soft palate close off the nasopharynx during swallowing. The adenoids close off the passageway, leading us to become that dreaded mouth breather. The pharyngotympanic tubes are the auditory tubes, eustachian tubes, open into the nasopharynx. We also have an oropharynx. The oropharynx is a passageway for food and air. The laryngeal pharynx is a passageway for food and air. The larynx is our voice box. The larynx has 3 functions. It has a passageway for air, a switch box for air and food, and it controls our voice box, our vocal folds. The trachea extends down through the mediastinum, held open by those C-shaped cartilage. The trachea has that ciliary escalator that sweeps things back up to the throat to be swallowed. The trachea. The bronchi and its subdivisions, making up the bronchial tree, still part of the conducting zone. We had a right and left primary bronchi. They branch out to each lung. The right one is wider, shorter, and more vertical than the left. So we see more crud in the right lung than we do in the left lung. After that, we go into the respiratory zone. The terminal bronchioles feed into a respiratory bronchioles. The little alveoli protrude from that respiratory bronchiole. The respiratory bronchioles lead into a widening alveolar duct. The alveolar duct leads into the terminal clusters of the alveolar or the alveolar sacs. The respiratory membrane, we spent a lot of time on this guy. The walls of the alveoli composed primarily of simple squamous epithelium. Simple, 1 layer thick. We call those cells type 1 cells. They sit over a very thin basal lamina. The external surfaces of the alveoli are densely covered with pulmonary capillaries. Capillaries only had one intima, tunica intima, one layer, simple squamous epithelium. So our respiratory membrane was simple squamous epithelium on one side, a couple of basal lamina, some fibers, and simple squamous epithelium on the other side. And simple squamous epithelium had intercellular clefts. And gaseous exchange occurs by simple diffusion from an area of high concentration to an area of lower concentration. Respiratory membrane. There were also some type 2 cuboids in there that secreted surfactant, and surfactant reduces surface tension. The lungs in the pleural coverings. The right lung had 3 lobes, the left lung had 2 lobes. They're separated by the mediastinum. The pleura, our pleural membrane, the pleura has a parietal pleura out around the cavity and a visceral pleura that's against the organs, the lungs. The pleura, it lines the thoracic wall and the diaphragm. The visceral layer covers the external lung surfaces. It secretes the pleural fluid that fills the cavity for lubrication. Pleurisy, inflammation of the pleura. There was some mechanics of breathing. Remember we talked about how we breathe, pulmonary ventilation, inspiration and expiration, and gas flows along a pressure gradient. And we needed our respiratory pressure to be negative 4 millibars, 4 millibars less than atmospheric pressure. We had some intrapleural pressure. The intrapleural pressure goes up and down with different phases of breathing, but it always equalizes atmospheric pressure, intrapulmonary. The intrapleural pressure we need to be negative 4 millibars, intrapleural. We maintain that because of the elasticity and recoil of the lungs, the surface tension of the alveoli, and the elasticity of the chest wall. And it also has some pleural fluid that has to remain minimal. We looked at pulmonary ventilation, inspiration and expiration, and Boyle's law. Remember Boyle's law? If volume goes up, pressure decreases and air goes in. If volume goes down, did I say that wrong? If volume goes up, pressure decreases and air goes in. If volume goes down, pressure increases and air goes out. Boyle's law. We looked at some physical factors that influence pulmonary ventilation during breathing. Resistance or drag. Remember we talked about resistance, airway resistance, a lot like our blood pressure and resistance to flow. The alveolus, lung compliance was the stretchability of our lung. We talked about our respiratory volumes and pulmonary function tests. The respiratory volumes, tidal volume, the amount of gas moved during normal quiet breathing. Inspiratory reserve, IRV, is that air that we can forcefully inspire over and above tidal volume. Expiratory volume is how much we could expire over and above tidal volume. Residual volume was the gas that stays in the lungs to keep it from collapsing. We use those volumes to calculate capacities. Inspiratory capacity, IC, is TV plus IRV. Functional residual capacity, FRC, is residual volume plus expiratory reserve volume. Vital capacity, all three: expiratory reserve, inspiratory reserve, and tidal volume. Total lung capacity, all four, the same three, plus residual volume. So we got ERV, IRV, TV, and residual volume. Dead space, anatomical dead space, is the air that fills the conducting passageways. Anatomical dead space is the air that fills the conducting zone, does not attribute to respiration. We talked about minute or total ventilation. We broke minute or total ventilation down into FEV1 and FeV2. FeV1 was the amount of gas that we could exhale in the first second. FeV2 was the amount of gas that we exhale in the second second. In COPD, FeV1 goes down. In COPD, FeV1 goes down. We talked about some other laws. Remember Dalton's law? In a mixture of gas, gas contributes to the total pressure in proportion with the concentration of that gas. And remember when we were talking about that, we broke it down into P, CO2, and PO2. Remember those? And then Henry's law, we talked about how soluble that gas was when it went into a liquid, or was absorbed into a liquid. Dalton's and Henry's. Internal respiration, the capillary gas exchange at the body tissue level. It's the exchange of gas between the blood and the body tissues, driven by partial pressure gradients of gases and that solubility that we talked about. Oxygen transport. We transport oxygen bound to hemoglobin in our RBCs. Carbon dioxide transport, we transport carbon dioxide as a ion. Oxygen binding and release is regulated by some factors: the partial pressure of the oxygen, the temperature, the blood pH, the partial pressure of the carbon dioxide. All of those are factors. All of those are factors. We talked about partial pressure of oxygen on our hemoglobin saturation point. And so oxygen saturation curve is steep. And so it usually causes very effective respiration. Temperature effect on respiration. We breathe easier in cold temperature. In metabolic tissues, the effect decreases the affinity in favor of oxygen, or favor of oxygen release from our hemoglobin. Carbon dioxide, we transport as a bicarbonate ion, HCO2, bicarbonate ion, H2CO3. So we transport carbon dioxide as a bicarbonate ion in plasma. The control of respiration, we had a medullary respiratory centers, the DRG and the VRG. The DRG set the pace and the VRG was unclear, but it was about forced respiration. We talked about some chemical factors, the chemical factors of our higher brain centers: oxygen and carbon dioxide and hydrogen ions. The chemoreceptors were central in the medulla and peripherally in the carotids. Increased carbon dioxide was the most potent and most closely controlled of the ions. Increasing PCO2 was controlled by chemical chemoreceptors. Carbon dioxide gets diffused into the spinal fluid. So we monitor carbon dioxide the most. We monitor our oxygen in the aortic arch and the carotid arteries. In COPD, carbon dioxide levels become chronically elevated. The chemoreceptors become less sensitive. Declining oxygen acts like a respiratory stimulus and develops a hypoxic curve. In COPD, we never, ever, ever give a patient pure oxygen. COPD's common factor is cigarette smoking, has been for years. COPD, the effect of exercising. It does, when we exercise, our respiratory rate only goes up minimally, but the intensity increases drastically. We looked at homeostatic imbalances of the respiratory system. COPD, chronic obstructive pulmonary disease. It's a major cause of death. Common factor, cigarette smoking. They include two conditions, or COPD includes two conditions: obstructive emphysema, and he was the pink puffer. Remember him? Because he was getting barrel-chested, but he was still getting gas in those unaffected sacs. And then chronic bronchitis was the blue bloater because he could not get the gas in, so he becomes cyanotic, his mucosa beds. Asthma.